Welcome to Whole Health. We're happy you're here on this journey of exploration with us as we learn what it means to live a life dedicated to spiritual, mental, and physical health. Before we begin our program, we want to share a brief legal disclaimer. The information provided on this program, including any health-related advice or discussions, is for general informational purposes only and should not be considered a substitute for professional medical advice, diagnosis, or treatment. Always consult a qualified healthcare professional before making any decisions regarding your health. Now, let's turn it over to Pastor Jeremy, Dr. Kala Kleen, and Brittany Pfeifner for today's episode of Whole Health.
Welcome to the show, everybody. Today, we're diving into a topic that affects millions of Americans, especially those in their 50s, 60s, and beyond. The growing challenges with healthcare costs, access to providers, and the limitations of our current Medicare and insurance-driven system. Here's the reality. Baby boomers are aging into Medicare at a rapid pace. We're talking nearly 70 million Medicare enrollees as of now, with tens of thousands turning 65 every month. At the same time, about half of our healthcare workforce, that's doctors, nurses, and other providers, is nearing retirement age, creating serious shortages. That means longer waits, fewer appointments, and strained access to labs and diagnostics. Medicare enrollment sits around 69 million as of late 25 or early 2026. The surge is largely driven by baby boomers. Meanwhile, primary care shortages are projected to worsen significantly in the coming decade. And I think underneath all of this is a bigger question people are starting to ask. Are we actually preventing disease? Or are we mostly managing it after it develops? Because most chronic diseases don't happen overnight. The body's often giving us signals long before a diagnosis appears, and that's where today's conversation really starts. So, Dr. Kala, would you kick us off?
Yeah, so often in practice, we see the impact daily. Patients wait months for specialist referrals. Medicare reimbursement rates often don't cover the time needed for complex multi-diagnosis cases common in patients over the age of 50. So many providers limit how many Medicare patients they can accept, which then further kind of worsens this access. So for those of us that are, not 65, not retired, that we aren't on Medicare yet, the bridge years can be especially tough with high premiums and the coverage gaps. So then this creates a perfect storm for higher cost and all focused on reactive care. So when it comes to insurance companies, so oftentimes when I worked in network, I didn't work for my patients coming in the door. My agreements and contracts are with Medicare, with Blue Cross Blue Shield, with United. So essentially, I actually work for them. They reimburse me for the work that I do, but I have to meet medical necessity in my documentation and note-taking in order to justify the care I want to deliver.
Right.
The reason of many, but one of the big reasons why I elected to basically break up and fire the insurance companies was so that I could work directly for the patient. So from my lens, it becomes so much more about the relationship and the trust. I still need to have due diligence. I still need to honor the patient's time, money, and health, but I then don't have to play by the insurance rules. So for instance, as a chiropractor, Medicare unfortunately just wants chiropractors to only adjust their spine. Wow. They don't want us to treat their hip or let me say that. They will allow us to treat shoulders and hips and knees, but they won't reimburse it for us.
Oh, wow.
But because I work for Medicare, then I get to have a lot more documentation to justify and explain to the patient, you have a hip issue, and I believe this to be bursitis. We can do soft tissue, trigger point dry needling, all this other care that your insurance policy doesn't cover. Wow. So then that's, more of a cost burden than on them. So I didn't like the red tape. I was spending way more time justifying in documentation than I was even being able to treat the patients to make it worth, our time as a provider. I hate not being in network. I hate creating a potential financial restriction, but in order to treat patients for what they need, we actually find not working for their insurance companies allows us to get quicker results and faster. Oftentimes too, when it comes to musculoskeletal pain, whether it's a hip pain or a neck pain or back pain, your insurance company directs the standard of care. So the standard of care, you can go to conventional medicine and it would be anti-inflammatories and pain pills. Right. They might recommend you to physical therapy. And after 6 weeks of failing out of conservative conventional care, then maybe we can get an x-ray. Maybe we can get the MRI to be diagnostic so we can understand more of what's going on. Right. Again, us being functional integrative chiropractic clinic, majority of patients that are at our doors don't want to go to the medication first.
Right.
With that. But again, those insurance companies heavily shape what's considered the standard of care. This often means treating the symptoms with medications rather than digging into the root causes like inflammation, gut health, nutrient status, movement patterns, sleep, and stress physiology. So then when it becomes the PCP, which is your primary care, and the patient payer triangle leads, doctors squeezed by short visit times and paperwork. So a friend of mine, she was in primary care. She was actually our family's primary care provider. And she said that hospital administrators were saying instead of 12-minute office visits, it needed to go to 8-minute office visits. So again, even more crunch time. And if you have 1 or 2 or 3 things going on, that's really hard on the provider to be able to capture enough information. From my lens, my patients will tell me, and I'll hear that, well, they were just really fast. They were in and out of the door. They had their hand on the door their entire time. And I extend so much grace because I've been on that side.
Sure.
It's part of the system. They're overburdened. They're supposed to see 65 patients in a day. And then the other part of that is they don't have time to explain maybe what a patient could be responsible for. Hey, if you want to work on this hip pain, we got to get you stronger in your glutes, and we need to get more of a workout or rehab plan in order to prevent further disruption of the hip condition like an osteoarthritis, so on and so forth. But insurance has also kind of, in my opinion, manipulated, if you will, what preventative healthcare is. Insurance defines prevention very narrowly. So think vaccines, mammograms, colonoscopies, and DEXA scans, and only when a certain criteria is met. For instance, DEXA, I think should be ran on patients at age 20 and again at age 40. But right now, the DEXA scan is over the age of 65. Many women don't know this, but if you went into early menopause, and that could be post-surgical, so if you had a hysterectomy, that is an overnight menopause, I would highly, highly recommend really pushing. Majority of insurance companies will then pay for the DEXA. But I also think you can do cash pay DEXA. A lot of, I can't remember, if you Googled cash pay DEXA near me, I'm sure you can find there's providers that are doing that. But again, it's more reactive. After you're diagnosable for osteoporosis, then you can get treatment. And again, it's often medication, where if we see somebody that at age 40 has, bone mineral depletion that is lower than what it should be for a 40-year-old, we can start doing interventions so that we don't have to wait until osteoporosis is the condition or diagnosable. But again, your insurance company says that doesn't meet the standard of care. That's not medically necessity yet.
Right.
So again, it just really fuels this very reactive care instead of true prevention.
And I think that's an important distinction, because what you're describing is that, well, disease doesn't usually appear out of nowhere. The body's giving us some pretty clear signals long before the crisis happens. But most people don't really enter the healthcare system in a serious way until those signals become loud enough to qualify as disease. And I think that's where people start hearing terms like preventative medicine or proactive care, but may not fully understand what that actually means in practice. And so, Brittany, maybe you could walk us through the difference between reactive medicine and proactive medicine, and why prevention often feels harder to access in today's healthcare system.
Yeah, absolutely. So traditional healthcare, unless you're in like the functional integrative realm, like what you know as healthcare, that's going to be traditional reactive healthcare, meaning what we're waiting for something to be wrong, waiting for disease, and then we do something about it. So like your blood sugar, it needs to be high enough. Your blood pressure needs to be high enough. Now we're going to treat the hypertension, or like Dr. Keller was saying, bone density is low enough. Now we're going to do something about it. But we're not doing anything before we get to a certain standard. And so in our practice, we'll have patients come in, they say, my labs are completely normal, like my primary care or whoever. And then we look at them, we're like, yeah, we can call this normal, but this is not optimal. Like their range, like we've talked about, I think their insulin goes up to 23. We want it below 7. Like that is a significant difference, So things like that. There's a lot of markers where our levels are different. So that I think is one of the biggest difference of preventive care, reactive care is like, 1, we have different standards. 2, we run different labs and we're looking for different things, and we're trying to get to it before it's to a place where we have to get aggressive and be on medications and things like that. Because we don't want to just, survive illness. Our goal isn't to just like, wait until we're sick enough to need something, right? We want to like reduce the likelihood of getting it in the first place. So again, that requires earlier education, lifestyle intervention, testing, things like that. But this are the biggest challenges. This takes time. It takes a lot of conversations. It's not sexy. People don't want to talk about nutrition and sleep and movement. This is kind of the general theme of this whole like show, right? Where we're like, get to the foundationals. But the everyday is just it's not flashy. So it's hard to talk about. And just our healthcare system isn't, built around that. The reimbursement for me sitting with someone and talking about nutrition for an hour is not nearly as significant as surgery, as medications, as all the follow-ups that come with it. So those types of things, that's just kind of how the traditional healthcare system is built. But most providers generally want to help people. It's just it's just not, structurally set up that way. Like if you prevent diabetes, there's no dramatic intervention. That's just not how it goes. And I think part of what's important about this conversation, my husband has a knee thing going on right now, and it's been a long term. He's done the whole failed out of PT, conservative, and so finally got the MRI, all that fun stuff. But what I thought, like watching this from the outside, has been extremely interesting because he went in for the consult and with the provider before the MRI with the surgeon, and they explained, well, we'll have to do the MRI. Once we get the results, then we'll know. And then he never met with the surgeon again. And he got the MRI results back. They're like, yeah, we'll do surgery. Never met with him. They never explained what they're doing for the surgery. And they don't, he's like called back to schedule. He's like, okay, if I do the surgery, like just really trying to fact find. He's like, how long is recovery? They're like, we don't know. We can't tell you. He's like, I have to take work off, like trying to just plan for like lifestyle. Right. And so that part was really interesting. He's like, I don't even know, like he wasn't aware. Are they repairing things? Are they just scoping it out? Like those details, because he never met with someone afterwards, like it was just like, you met, you got the condition, you're scheduled. And I was like, this is so interesting to watch happen, because I would have a million questions myself. And I'd be like, but even him who doesn't generally, dig into things as much, he definitely is now. And it's a whole other thing. But I'm like, interesting to see how this goes for someone like that's not totally in this realm. And he was questioning, like, how this goes? Why is this not explained to me? I don't even. And so I was like, you can request the doctor's note.
I think we're conditioned not to, though. When I sit in a doctor's office, not yours, but I was recently told that I only needed to see my doctor. I have to take a medication on a regular basis for GERD, which I don't really have, but it's a long story, connected to a surgery that went bad. And they used to make me come in every 3 months for testing, and then they moved it to every 6 months. And then at my last visit, they said, we only need to see you once a year. And it's not because my symptoms have gotten better or gone away, but because they just don't have time to see you anymore. Mm-hmm. And we're conditioned to not ask questions, to not push back, to just... they're wearing the white coat and you have the stethoscope around their neck. And so they're the ones with all the answers, and we're not supposed to ask all the questions. And I'm not saying they say that to us, but that's how they, I think, make us feel from my side of the equation. And I've had, aggressive surgeries and understand what your husband's going through. I talked to him a little bit about it, and that's not fun. Being on the outside looking in and wondering, well, I've got a family to provide for and work to take off. Yeah, my heart breaks. That's too bad.
Well, and again, I'm always going to be on the defense probably more often than not for the providers that work in network, because this is, again, fundamentally, they had the initial appointment, but a downfall in the system is he should have had the MRI before that consult, because he failed out of that conservative management with the physical therapy, with the dry needling, all the soft tissue work. But again, from my lens, would it have been great to have the MRI at the onset of the knee injury? To better understand, like, are you going to be rehabable? Right. Or is that meniscus so far gone? And then, again, conversationally, doing that rehab still made him stronger above and below where the knee injury was. So that's going to give a better outcome if surgical intervention is needed. But Brittany, you were sharing this with me while we were walking in.
Interestingly, this is so fun. He's trying to do all this research about what the best, course of action is. Because, after you do surgery, things are never the same. Right. It's, there could be scar tissue, there could be complications. It's not something to do lightly. I think surgeries are done really often. And sometimes we don't always think about the long term. Like my husband's early 30s. Like, what is this going to be like in 10, 20 years? So, things the way where he works an active job, he has to be able to run. So, those are things that he needs. But when all this started, he changed up his diet. He did carnivore for a little bit, pain in his knee completely gone, added some foods back in, but keeping very low inflammation, very low carbs, again, pain gone. So when we talk about gut health and nutrition and and it's like, okay, so at this point he's pushing off surgery because he's like, if I can fix, this issue with it, manage it, inflammation, things like that. If this is doable, and he's going to kind of test the waters and see what he can do. But
that's awesome.
it's
I've
again,
heard a
it's
lot of great things
significant.
about the carnivore diet, experimented with it a little myself. I know it's maybe not for everybody, but boy, when you talk about being able to clear out your system, it's a
Mhm.
great way to accomplish that.
It absolutely is. So, yeah, but back to like the preventative, reactive care. I think one aspect that is interesting to talk about is like people all say, it's expensive when we talk about
Sure.
integrated functional medicine. Like that's kind of one of the big things that comes up. But we talk about like culturally spending money after your disease develops. That's completely
Right.
normal, right? You
Right.
spend it on medications, hospital bills, surgeries. No one's like, oh my goodness, you're spending that much on it.
Right.
But when we talk about like strength training, buying quality food, preventative labs, health coaching, and all of a sudden it's like, oh, you're extreme, you're spending a lot of money. But that investment is on the front end. Like we're investing in long-term health and aging
Right.
well instead of on the back end.
Yeah.
Well, and I'd like to kind of add too, I've said this before, but if we look at people who are trying to do everything right, from the preventative and longevity standpoint, and we compare it to people who have cardiovascular disease, type 2 diabetes, uh, hypertension, deconditioned, all of those things, and we compare them side by side, the very sick crew, everything that they need to be doing looks very similar to what the people that are doing to try to prevent disease in the first place,
Mhm.
on how they're doing it, what they're doing. But again, we can take somebody very chronically ill, having a lot of things going on, and we can get them to that optimal range, but it requires their commitment and their buy-in. So basically like a partnership. Right now we see in conventional medicine, it's this is what the doctor said, this is what my insurance pays, and the patient has very little say or
Right.
involvement in that interaction, where on the preventative side it's way more like you cut the insurance out and you work together in relationship of what is realistic and idealistic right now. Hearing about Taylor at his age and what he's been able to do, that might not be a realistic story for somebody who's a 65-year-old
Right.
woman,
Mhm.
right? And again, it's really important that the provider understands there's ideal and then there's realistic. Ideal, sure, being on that diet for the rest of your life at 65, but I'll argue if you're at 65, can we get you healthy enough that maybe you should have the knee replacement or the knee surgery because you're compensating the way you're walking, you're deconditioning because it hurts so much to walk on it.
Right.
It might be more reasonable to have a more invasive approach like a knee replacement or knee surgery for the 65-year-old compared to the sub 40-year-old.
Right. And all that, I think, kind of shifts back to the cost factor as well. A lot of the conditions driving healthcare costs right now are not rare diseases or sudden illnesses. They're the, kind of chronic everyday conditions that slowly build over the years through inflammation, through poor metabolic health, muscle loss, sedentary living, stress, and certainly nutrition patterns. Boy, that seems to be getting worse. What's sobering is that so many of the top health concerns affecting adults over 50 are either preventable, significantly improvable, or at least heavily influenced by lifestyle and daily habits. And so, Dr. Kellett, when you look at the patients that are coming through your office every day, what are their biggest conditions dominating care right now?
Sure. So, on the integrative and functional side of thing, 85% of visits for people 50 years old and older involve conditions that are largely preventable and improvable through diet and lifestyle alone. In this age group, so we have multiple diagnoses, and that leads to something that's called like polypharmacy. So
Hmm.
we have multiple conditions. So there's a heart issue, there's a blood sugar issue, there is a metabolic syndrome issue, and then one of the things that people don't talk about is age-related muscle loss. What we see, they're like, that's just normal. You lose muscle with age. And again, we're normalizing things that don't need to be normalized.
Right.
But then again, the thing that, people raise an eyebrow to is that cognitive and mood issues as well. So these conditions respond incredibly well to foundational changes, that blood sugar balance for diabetes, anti-inflammation for eating, for heart disease and GI issues, and then that strength training for both bone and muscle gain. Kidney disease is often the downstream of uncontrolled diabetes or hypertension, leading to, again, further GI distress, frequently ties back to diet, the microbiome, and the standard of care may only medicate all of those things. So
Hmm.
again, you have a cluster of a couple different conditions that have overlap and complicating each other. And again, diet and lifestyle is never talked about in the
Right.
conventional model. There's no insurance that is reimbursing for that. I should take that back. There are more and more that are now for type 2 and insulin resistance, and some with the GI that now via telehealth, there's a registered dietetic
No.
that they can reach out to. The hard thing about the registered dietetic, and my sister-in-law is one, I have lots of friends that have gone that route, but it's still largely controlled by an old school food pyramid.
Sure.
And again, I know that that's some of the stuff that they're trying to change with the MAHA movement
Yep.
and doing a lot more with diet, which is, again, I think it's really exciting. Sometimes people can listen to this and get really sad and depressed and feel like there's no hope. I do think that there's been meaningful change happening. But again, with the patient, you want to try to be able to get the baseline of what's the most 911 right now. Some people absolutely need the medications because they're so inflamed or the disease is so far progressed. But again, as we start incorporating the diet lifestyle, we can reduce those medications safely. And a lot of the times patients can come off of them and not need to rely on them.
That's awesome. I think for a lot of people, it's where the conversation becomes more personal because most people know somebody, maybe that's themselves or a parent or a spouse, somebody who started with one health issue and then over time it slowly became multiple health issues. One medication turned into several, one symptom became a bigger pattern of many symptoms. And I think sometimes people don't realize how connected all of those systems actually are. And so, Dr. Kalla, would you please explain what people mean when they talk about the medication cascade and how chronic dysfunction tends to build over time?
Yeah, so one of the easiest examples, oftentimes we're seeing teenagers being prescribed a birth control for other things
Right.
other than birth control. Sometimes it is,
Hmm.
which is sad and unfortunate,
Yeah.
but they're prescribing birth control for like acne and mood swings,
Oh,
and
wow.
they've named clusters of symptoms like PMDD and PMS, and those things are all real and manifest
Sure.
as real. But what they see, especially when we put teen girls on a birth control, 6 months later or within 6 months, there is either anxiety pill, a depression pill, or a sleep aid.
Oh,
And so that's what we mean by cascade is
yeah.
that we have one medication prescribed for X, Y, and Z reason. Then we have another medication for the side effect of the
Gosh.
first medication. So, and it's not anti-medication. Many medications are absolutely necessary and life-saving. But what we're talking about is how chronic dysfunction tends to compound over time when an underlying physiology driving is never fully addressed. So, you would have a patient that are hypertensive, or they have high cholesterol. I'll use the high cholesterol one. So we put them on a statin drug, and oftentimes we'll see primary cares that they'll be retesting to see, are we driving the bad cholesterol down?
Yep.
And so let's say we start somebody on 10 milligrams and we retest them in 12 weeks and we see it didn't lower it enough. Well, now we're upping it to 20 milligrams. Then we're upping it to 30 because the standard of care is just to drive those biomarkers down alone.
Hmm.
Mind you, in that time, they're not doing cardiac calcium CT tests. They're not doing stress echophysiology. They're not understanding, well, based on this high cholesterol, do we have any soft plaque in the carotids? Do we have any soft plaque in the heart?
Right.
It's just purely based on those very basic biomarkers. And so you might have somebody on 40 grams of statin, which we know the drug-induced micronutrient depletion of statins drive liver CoQ10. CoQ10 is really helpful for joint and low back pain.
Right.
So oftentimes I tease statins are really good for a chiropractor's business because your back pain and joints are going to hurt a lot more, which is, rather
Isn't that
unfortunate.
fascinating?
But, typically the higher the statin drug, it's really a matter of when is insulin resistance, when is type 2 diabetes going to show up, especially when we didn't address why do we have a cholesterol problem in the first place? Is your cholesterol problem purely genetic?
Yeah.
Has nothing to do with diet lifestyle? Is your cholesterol because we have very high animal protein, but not enough omega-3 to combat that pro-inflammatory omega-6? So again, when we're not addressing everybody's entire diagnosis, we get tunnel vision,
Sure.
and we just treat that one condition and not look globally. So again, someone might start developing insulin resistance years before they were even diagnosed with type 2 diabetes. So initially it might look like fatigue after meals, more cravings, weight gain around the abdomen, energy crashes, poor sleep. And then we can see it clinically when a fasting insulin is climbing while glucose is still appearing normal. So that's why, again, we're just so hard pressed on expanded labs, not just the bare minimum, so we can get a complete picture.
Sure.
I have seen people with a fasting insulin of 30, but a fasting glucose of 85, which is ideal and optimal.
Hmm.
So, but that's very misleading.
Yeah.
Even though their insulin really high is being able to get a fasted state, but when we compare, it's like we know there's a physiologic problem, and
Well, that's fascinating.
Yeah, yeah. Again, then too, we can see over time if blood sugar is worsening, inflammation and vascular inflammation is going to increase, visceral fat increases. So we might have somebody that hasn't changed weight. They just stay the same body weight, 175 pounds in 3 years, and they haven't changed weight. But what we see is that they're losing muscle mass, but gaining visceral body fat. Visceral body fat, we talk about, it's the fat you can't see. So we
Right.
have a lot of people who are walking around in what we call the skinny fat. Their BMI looks great and fantastic, but they have such low skeletal muscle and such high body fat, but they're being told you're very healthy and this looks
Oh,
good.
wow.
And then two, to the defense, we have some people like, well, Brittany and I, we've joked about this before. We got an in-body and I stood on the scale and Brittany's like, oh my gosh, you weigh a lot. And I
As
like,
in, like, you are extremely muscular. We weigh almost the same. I am a lot taller than her, so that's
and I was not offended. In fact, I took it as a compliment. I was like, I know, talk about big bones and a lot of muscle.
yeah.
I love it.
But my
Oh my
BMI
gosh.
shows that I am unhealthy,
Right.
which is, it's not true. So again, you kind of just get these cascades though that aren't being monitored, that aren't being addressed. And so you just, especially too, when we start one medication, we would hope that that's a wake up call of, hey, we can influence things to not need that long term. So it's realizing that systems are not separate from each other. The same inflammation contributing to insulin resistance may be also contributing to vascular dysfunction, cognitive decline, hormone imbalance, poor sleep, if poor sleep isn't also another contributing driver of this. So the earlier the intervention question becomes incredibly important. There are often years of this physiology where it's shifting. I've seen it. Patients will bring me their labs where I'll see their ALT and AST, which are liver enzymes, that they're slowly creeping up. And it's not until all of a sudden now you're full-blown liver disease or
Right.
non-alcoholic fatty liver that then again, here's a medication versus can we mobilize some of that fatty liver and can we get that down? And again, some patients are absolutely not motivated and they want the med. That's
Right.
great. Stick to the conventional medical model. But some of that sobering reality of we have a healthcare crisis and you don't want to be a victim of I need to get in. And now they
Right.
can't be seeing me because something has been really profound, like a cancer diagnosis, or unfortunately, if you suffer a stroke or heart attack,
Right.
and getting some of those interventions so that you don't get recurrence.
I think one of the reasons preventative health matters so much is because many of the most serious diseases don't always give obvious warning signs early on. Heart disease is a perfect example of that because I think a lot of people assume, well, if something's wrong with my heart, I'm going to know that, but that's not really how it works. So, Dr. Calla, talk about why cardiovascular disease can progress silently for so long and why prevention matters so much here in this realm.
Yeah, so sobering reality in medicine is that for many people, the first symptom of cardiovascular disease is actually like the heart attack itself.
Right.
Fortunately, unfortunately, sometimes that is the wake up call that people after they have it. I often see the opposite. After the heart attack, after the stroke, now people are motivated, which again, we'll still celebrate the motivation.
Yeah.
My bias is like, but this could be prevented at such an earlier age. So some of the things that we do, again, those advanced cardiovascular biomarkers. So what we do know is statistically is that over 50% of patients showing up to the emergency room with a confirmed stroke or heart attack have had normal blood pressure and normal conventional lipids from what they've been told.
Wow. That's pretty wild.
Yeah. And so Jill Reese is the physician assistant in our office. And I love Jill and I's story. She first came to me. So she's a physician assistant working in the emergency room. And at her first encounter, and she doesn't mind me telling this story, she's like, I got to tell you, the fact that I'm sitting in a chiropractic office asking for labs, like people think hell must have frozen over.
Right.
And she's like, but I don't feel good. And I've had a couple friends come to you. So I want to see what this is all about.
I love that.
And I said, hey, for the next 30 days while we're waiting on your labs, I want you to count how many strokes and heart attacks are coming in. And I want you to look through their
Wow.
chart to see how many of them were ever medicated and have been going to their primary care. And she texted me like 2 weeks later. She's like, this is absolutely shocking what she was observing. And I
Yeah.
told her, I go, but you know what alarms me the most about that statistic is that means the other 50% are medicated.
Hmm.
And they're still having a stroke and heart attack.
Right.
And so as Jill got her labs back and we continued to grow, in our professional relationship, she's like, this is really interesting to me. And I was like, I'll tell you what, I go, I run a bunch of these cardiovascular biomarkers and send people back to their primary care because I think they need a second set of eyes
Yeah.
over this. Some people, I do believe, because the disease state is so advanced that maybe for some people, they actually should be on a medication.
Sure.
But some of their providers were saying, this is a chiropractor, this is quackery, you don't need a
Oh my
medication.
goodness.
And so then is what I was observing is that I was creating medical anxiety or chaos because they
Oh,
have supposedly the chiropractor who doesn't like meds, doesn't like statins,
right.
saying, I think you need them.
Oh my
And then
goodness.
the prescribing authority saying because of an ego, right,
Yeah.
that it was coming from a chiropractor. But thankfully, Jill, she's like, I want to go into it. So she has been such a huge blessing to our office and to our patients. She has been able to take the lead on some of this preventative, especially starting at age 40, getting stress echoes, running these more advanced panels on patients to understand where they're at. And then again, over time, diet, lifestyle. And two, we work for our patients. We don't want to use meds if we don't have to. There's,
Sure.
Again, so some patients be like, thank you for telling me what I could do on this med. I'm going to elect to do this first, but then we retest to make sure the diet lifestyle changes have created meaningful impact and risk reduction for that. But as it pertains to this silent killer, half of first heart attacks occur in people without previously diagnosed. And that's because the plaque buildup develops gradually and over decades. The body compensates remarkably well for a long period of time. And again, God created this, right?
Right.
He created our ability to adapt, and our body is trying to do what it can. But if that chronic bombardment, there's only so long that our homeostasis can do what it can. But blood vessels can narrow slowly without obvious symptoms until blood flow becomes critically impaired and plaque ruptures.
Wow.
So someone may feel fine while the disease is silently progressing underneath the surface. So biomarkers alone are just a small window. It's not the entire picture. There are usually earlier metabolic and inflammatory patterns developing before. And again, insulin resistance, people think, oh, I don't have a blood sugar issue. And it's like, you don't yet.
Right.
But the higher your insulin goes, we know that that's going to be an inflammatory burden. And if you have normal LDL cholesterol, your doctor might be high-fiving you. But if you have an elevated lipoprotein A, which has nothing to do with diet, lifestyle, and all purely genetic, that could be silently creating this plaque buildup that you're not feeling.
Right. And that's my story. I've been doing blood work my whole adult life. And until I came into your office and got my blood work done, I never knew that I had not just a high LP little a, lipoprotein A, but like skyrocketed high, which carries with it an increased risk, I guess a significant risk of a, significant cardiovascular event. And, there's not really a whole lot you can do about the LP little a right now. There's some things you can kind of fiddle with, but you can prevent the, possibility of this major catastrophic event by focusing in other areas, making sure your triglycerides are, and those are all the things you walked me through. I actually saw the PA and what was she ran the test?
She did the carotid intima thickness test.
Yep. And then you sent me to get my heart checked out. And, that was amazing for me. I've actually since had it done, all of my sons, and they all have that. My brothers do in Arizona. So we're a family of LP little A's, I guess. But because we know that, we're able to focus on other areas to make sure that, we still have that great quality of life, the, lives that the Lord, He knows the number of our days. Thank God for that. We don't have to worry. But, we still want to live the best life that we can to, be with our family and our friends and fulfill the, call that God has on us. And if, we're able to just find those little things. But I came to find out most doctors in the United States don't even test for LP little a because, as of yet, I'm told that there is something coming on the market at some point in the not too distant future. Big Pharma has something that, quite frankly, as I was reading about it, I thought, well, that's not for me. But
did you see the vector on how it's being used?
I haven't.
Okay,
yet.
so there's two things. Since you and I last met, actually, Jill and I just yesterday, we did find out that there's a University of Iowa doctor who is trained in apheresis for lipoprotein A. So before, we would send people to Mayo Clinic if they had a level over 400, 500. I don't remember what your level was.
Right at that 400-ish mark, yeah.
So we actually, Jill reached out to hit this provider yesterday because you can get your blood siphoned and it actually can be very protective for this LP little a. I'm more biased to that as of right now because based on the LP little a medications on the market, from my understanding, they are using mRNA technology.
That's what I'm reading.
And I have a big red flag.
Not interested.
Anybody I love in my patients, I would say I haven't seen enough evidence.
Right.
I would need it to be on the market for a good 20 years.
Right.
Because what's going to be shown in the studies is how it pertains to cardiovascular disease. My concern is the oncogenesis. I have some big concerns on what mRNA technology does from a cancer fuel, cancer creation.
Sure.
So I think what we're going to see in the study is that, yes, it does drive down Lp(a) if it gets FDA approved. But I have such a red flag on.
Yeah, focus on the other areas. Blood siphoning, is that like the filtering kind of?
Yeah, so you're probably used to seeing it probably like an EBO.
EBO, yeah.
Yeah.
I've looked at some of that. I know Mayo Clinic will do that as well.
Yeah, there's a
There's
clinic in Sheridan.
Yep. I think North Liberty has a new one as well, and then you can go to Chicago and there's a bunch and get pizza, but that's probably counterproductive.
Sure. Yeah, a really good friend of mine in Arizona owns Valley Spinal Care, and what he tells me about EBO, I think no matter what, EBO is a very fascinating thing.
Right, I'm fascinated by it.
Yeah.
The three of us should go do it together.
Yeah, and let's go to Arizona. Let's go to Justin's clinic and do it. But EBO, I don't know how EBO does as it pertains to Lp(a), but the apheresis is very specific to siphon to pull out the lipids, pull out the excess cholesterol. So you're basically cleaning your blood and it gets put back in your body. To me, even though that's invasive, it is still more natural without the use of a medication.
Right.
So that's why I think it's more promising. And so I look forward to seeing what he says, especially to have like a consult as a patient that has elevated Lp(a) would be very worthwhile. So again, kind of back into our world with
Sorry.
No, yeah, then we digress. When it comes to that cardiovascular disease, patients can really be the drivers and be the preventative. You can ask your providers to run these tests on you. We have been seeing actually great insurance coverage, especially if you have the conventional lipids, if there is elevation. For the two biomarkers is we want you to have is a fasting insulin, a hemoglobin A1C, your fasting glucose as well to get context, but then that apolipoprotein B and then lipoprotein A. Those help tell a little bit more of a idea. Again, though, you can always ask if you have chest pain, if you have chest pain on exertion, even if you're deconditioned, sometimes then you can get your primary care to order a cardiac stress or a cardiac echo or a stress echo. And so again, we tell people when you hit 40, go get your advanced biomarkers, get the carotid intima, get the calcium CT. The thing about the calcium or the cardiac CT is that it's only detecting hard plaque. But if you have hard plaque, that tells us that there's probably soft plaque as well. We can make assumptions. A lot of people don't know because it happens over time or because of age deconditioning, that they didn't realize that they were short of breath, not because they're deconditioned, but because their valve, the arteries are on the heart, that there's stenosis. So their heart is having to work a lot harder for that. Again, we hear so many stories that after the fact are like, they said it was the biggest, most hypertrophied valve that they'd ever known. Some people are really good at rubbing dirt on it, that they just push through and suffer through. So I think they're good conversations to be having, to be more in the preventative, but it needs to be patient-led.
Yeah, I think no doubt the system has real limitations, but you own your health outcomes more than you might realize. Preventing or reversing chronic disease, it takes consistent work. It's not always easy or quick, but the payoff in quality of life and reduced costs can be enormous. Brittany, would you share what that looks like, on a practical level?
Yeah. So, I mean, we kind of talk these foundational things pretty much every episode, but that's because they're so important. Just nutrition and daily habits is where food, movement, they're the biggest levers when it comes to changing your long-term health outcomes. And I think it's hard when you first start, and that's why a lot of people will jump to the medication because I don't want to call it an easy button, because once you start things actually, the cascade, that's not easy. It's not easy to not feel well and to kind of have to go down that rabbit hole. But like, I love the phrase, choose your hard. You're going to choose the hard now or you choose the hard later. And so the prevention doesn't have to start with extreme things. I think a lot of people think they have to completely overhaul their life, but truly changing one habit a day is going to make a big difference. What do they say? It takes 30 days to create a habit. So, just changing one thing and focusing on that. You don't have to spend a whole month on one thing, but if the motivation, it's going to start to be there. When you change your diet, at first it is really hard because when you crave unhealthy foods and that's what your body knows, but 30 days in, now you're craving fresh vegetables, you're craving things and then when you do, have those other foods you used to eat, the more processed things, now they don't taste good to you anymore. Right. So, but you have to put in the sweat equity and the work to get to that place. But I think that's where it gets a little discouraging, is because the hard that it is when you first start is not the hard it is forever. You kind of have to push through that phase for it to get to the other side. It's like the runner's high, it sucks until it doesn't. Right. And so one of the first places that I think is really crucial for people to start is the blood sugar leveling and just making sure we don't have these spikes and lowering inflammation all the time. I think this is really under talked about because like until I was in this health realm, like I know movement, sleep,
Sure.
things like that. Those are pretty foundational. But until you understand the body a little bit more, you don't understand like how significant like feeding your kid like a carb heavy breakfast, how that's really not setting them up for a good
Right.
day. Like that blood sugar spike. So now like, if your kids have attention issues or hyperactivity, things like that, literally adding protein in with their breakfast is
Right.
going to make a big difference. Like we need to fuel well so we can start
I
our
think
day
we were
well.
told that oatmeal was the best breakfast for the longest time, and then you find out, well, that's maybe not the best idea. Go straight for the eggs.
Absolutely. And I mean, there are things like we're not saying you can't ever have carbs for breakfast,
Right.
but like we need to balance things out. So if you're going to have oatmeal, I like to add fat into it. I like to add it with a side of like chicken sausage or something to just kind of level things out. We're not like carb shaming because we
Sure.
need carbs.
Yeah,
Like, we need
100%.
fuel, but we need that to not be the main thing we eat and the only thing we eat. Protein is so crucial. And I find, I talk to a lot of parents whose kids don't like protein. And I think, and every kid's different, and it's it's not as simple as just make them eat it. But
Right.
if the younger you start, and the more you serve it, and serve in different ways. If your kid doesn't like something cooked a certain way, just try to do your best to change it up and see what they like. My kids eat protein really well because like I just knew it was important, so
Right.
we just served it their whole lives, all different types,
That's
all
all
the
they've
time.
known.
Like my 1-year-old, all of them have loved shrimp, but they're like, this kid will eat 12 shrimp. And I'm
Wow.
like, yeah, because like I know a lot of kids who just won't do fish, and we just made it a priority to like incorporate it young,
That's cool.
so things like that. So if you have young kids, starting young is fantastic and building those habits as they're young. But if you don't, then again, we just start where we're at, right? Start to do it introduce it. And then one of the things I say in like food therapy, play therapy, you just need to keep introducing things. If you introduce it, it doesn't go well, try again. Try a different way. If they don't like broccoli steamed, try it raw. Let them dip it in some
Right.
ranch. Figure out a way that I think we can
Right.
start to like things, right? So there's practical steps that you can do. We don't have to make it as complicated, I think, as we think it is, if that makes sense.
Sure.
So another aspect is movement. I know we talk about that all the time, but our bodies were designed for regular movement. Going on hitting 10,000 steps, going on a long walk and say, that's great, but what's better is movement throughout the day. And I know that's
Sure.
not attainable for everyone with the job that you have or how your life looks, but if you can get a good movement in the morning, and it doesn't need to be a full workout, but just something, get some sunlight in your eyeballs, move your body, eat a good breakfast. If you can move after you eat, if you're working in an office and you can't do some squats, you might be the
Sure.
weirdo in the office doing squats, but it's going to be helpful for your glucose
Right.
uptake, everything. So just adding those small movements in throughout the day. Now I'm saying if you can't do that and you just do a big walk, that is better than nothing.
Sure,
Absolutely.
yeah.
But smaller parts throughout the day are going to be more beneficial. And I think one of the other aspects to this, I think, is just taking ownership of our health.
Yeah.
So we talk about all these different things that you can do. And like I said, it kind of gets overwhelming sometimes, but just taking ownership of your body and realizing like, this is my body that God gave me. This is the only body I get. Do we want to age well when I'm a grandparent? Do I want to be able to play on the floor with my grandkids and get up? Do I want to have
Right.
independence? You know how expensive nursing homes are?
Right.
Like these
I
are
do.
real things that if you wait until you're 70 to start thinking about it, it's going to be so much harder.
Yeah.
So we invest in our health when we're young. Teaching our kids how to do it, fantastic. But if you haven't grown up like that, then doing it now is, start where you are and start to add things in one thing at a time. If you're like, okay, first let's just start on nutrition. Let's add some protein and let's cut some other foods out. Let's start to move our bodies. And those foundational aspects, which are so simple on paper.
Right.
I mean, it takes time, it takes energy, it takes intention to do. But that's the biggest impacts that we see in our clinic all the time. Patients who do these foundational things get better so much faster than the patients who are just on 30 different supplements.
I love hearing that.
Well, and I'm just thinking like generationally, too, depending on the listeners, sure, we've got the audience that this was more targeted towards of like the 50 to 65-year-old of just the impacts of aging and, things that we need to consider of the silent killers and the different metabolic diseases. But like if we were to take like 3 generations, we've got grandparents, kids that are, sandwiched right in the middle, and then the grandkids. But grandparents are usually retired and they have a lot more time.
Right.
And those are the things that's like, okay, what can they do because they've got so much time? It's like, hey, can you help the parents that are either working and raising 4 kids at the same time? Can we do like a meal prep, where you're doing the no-bake energy balls? My thing with the whole oatmeal too in the mornings with kids, if our kids have soccer, it's like the weekend where we know that they have time to go expend all of their energy, then we're like, yeah, they can have the carbs in the morning for their first meal because they need it.
They're going to burn it.
Yeah, but then always what we do is they get more carbs like after school. So high protein in the morning because they're just going to go sit in a desk all day.
Right.
But if it's before their practices or they're going to be running around in the neighborhood, that's when you grab like the overnight oats.
Yeah.
But, grandparents have a lot more time to be able to help. Like, okay, what can we do amongst 3 generations that can help those that are working, and then 2 for the next generation, so that I think healthy is contagious, and it's just easier when everybody is helping out and being a part of it.
I love that. I think one of the most encouraging parts of the conversation really is just knowing that it is a team effort.
Mm-hmm.
I mean, you have family that can come together and do things like that. You can, seek out, advice from incredible folks like you. But, back to your point, Brittany, you own your health, and, you're going to get out what you put in. When people hear the words, like chronic illness or healthcare crisis, I think it can feel overwhelming, though. Those are things that are triggers for some people. But for so much of our long-term health, it's shaped by kind of those daily choices that are actually within our control. And at the same time, I think a lot of people intuitively know when something feels off, even if they've technically been told everything's okay. I've experienced that a few times. And that's why more people are starting to seek out, deeper testing, more personalized care, providers who are willing to look upstream instead of just reacting once disease becomes severe. So, Dr. Kella, talk about the importance of getting better data and building the right kind of support team when somebody wants to take a more proactive approach to their health.
Yeah, so I think better data is one part, but just getting data, step one, let's just get the data. So most of the time for most insurance companies, regardless whether it's Medicare, Medicaid, Blue Cross Blue Shield, United, typically you can get a vitamin D, magnesium, CRP, full thyroid with antibodies. And this is something that patients will probably have to really encourage their provider to run. Give your provider some grace if they say your insurance won't cover it. Just get as much as you can, a hemoglobin A1C, that fasting insulin. And that's going to tell us so much from intro baseline. Then from a DEXA, again, I've had some patients that have been runners. Runners are a great excuse to, if you say that you've been running more than 10 miles a week and you're at the age of 40 or above, that can get you a DEXA earlier and covered by your insurance. Again, don't wait for your insurance to cover it. If this is appealing to you to go get that priority, you can Google what your DEXA scans mean, and it'll tell you within great definition. So we have a T score and a Z score. T score is your bone density compared to a 30-year-old. A Z score is your bone density compared to your peers of your age. I think that's really, really, really important. You can prioritize this weight-bearing exercise, the balance training, and then some of your key metabolic nutrients. And again, I think it's just so helpful to look up, consider functional or integrative providers. There's a lot. They're flying up all the time.
Yep.
Conventional medical providers are fleeing conventional medicine and opening up clinics, which I am thankful for. I think it's great. There's such a need. There are a bunch of the cookie cutter models, things that are membership. Everybody gets the exact same plan. Those things I think can be difficult because then you lose out on that individualized. We can have 3 40-year-old women all have completely different things going on. So sometimes those membership services, just ask for friends, ask for the referrals of who other people are going to kind of help understand, providers that work with you versus this is just a good business model. But many patients will find, especially the patients that are under the age of 50, especially in the Cedar Rapids corridor region, I would say majority of insurances are high deductible, which I would love to talk more about next time. Jeremy, before this episode, you were bringing up just the cost of insurance in general and premiums and how to use maybe high deductibles and HSA dollars to patients' benefits for some of these.
Yeah, it's a great idea.
So we can maybe do that the next time. But because in our opinion, the reason why it's really helpful to do that now, especially before the age of 50 or 60, is that we have access to be able to reverse and strongly manage chronic disease in the first place. Many patients reduce medications and feel years younger when they do work. We've had many patients that come to us post-cancer. So they're in recovery. They have beat the cancer, which is really great, but they feel they're like, I need to get my body back after the chemo or the radiation. And oftentimes within 18 months, which truly 18 months is not a long time, we have many patients saying, I'm healthier now than I was before I ever had cancer. And that's
awesome.
That's victory,
Yeah.
right? And it's empowering.
That's a huge win.
Yeah. So it's exciting to sit back and see this. In my opinion, this is more motivating than it is paralyzing in fear.
Right.
Yeah.
So let's recap. Systemic pressures are real, provider shortages, costs, reactive care, but your daily choices and proactive steps can dramatically improve outcomes. And I think one of the biggest takeaways from today's conversation is realizing that prevention really isn't about perfection. It's not about obsessing over your health. It's not about trying to control every possible outcome, but what we can do is steward the body that we've been given with wisdom and intentionality, because health impacts almost every part of your life. Your energy, your independence, your ability to serve others, your ability to stay present with the people that you love. And many of the things that move the needle most are actually simple. Sleep, movement, strength, whole foods, community, rest, and consistent daily habits. We're really grateful that you joined us for this conversation today and chose to spend part of your time with us. If you want to listen to past episodes, I'd encourage you, head over to wholehealthlive.com and then hit that listen tab at the top of the page. On there, you can also get to know these lovely ladies on the hosts page, so you can click that and even find links to their scheduling pages on their clinic website. I'd encourage you to take advantage of that. So until next time, thank you so much for joining us. May the Lord bless you and keep you until He comes.
Thanks for joining us today on Whole Health. If you'd like to learn more about our program, have a question for our hosts, or want to find past episodes, just head to wholehealthlive.com.